I'm Bob Wachter. I'm chair of the Department of Medicine. And today, thrilled to hear a talk about an incredibly important problem and one where the science is evolving extraordinarily quickly, the science of diagnosis, the science of treatment. And we are lucky enough to have really a world-class program in prostate cancer at UCSF and led by a world-class leader who you'll hear from today. So our speaker is Rahul Aggarwal, who is the Thomas Perkins Distinguished Professor of Cancer Research in our Division of Hematology and Oncology at UCSF Health. He's also the program director of the GU Medical Oncology Program. Rahul is an internationally respected clinician, teacher, and a leader in clinical research, really advancing our understanding of how to manage this extraordinarily common cancer. Rahul did undergraduate and medical school at Northwestern and came out here for his residency and has stayed for residency, fellowship, and faculty, and has made a great difference for us and more importantly for the many patients he's taken care of and through his own clinical care and his research. So the talk today is called Prostate Cancer in 2024, Recent Updates and Treatment Advances. Rahul, thank you.
Thank you so much, Bob. And yeah, it's been an incredible time here at UCSF over now 15 plus years, hard to believe. But yeah, just extraordinary mentorship and collaborators over the years. So really proud and excited to get the chance to present updates in prostate cancer in 2024. There's certainly a fast moving space. There's been a lot happening. Too much to cover in a single hour, but just wanted to hit some of the highlights today, and certainly we'll leave some room for questions as well. Here are my disclosures. So a couple of the learning objectives for today, trying to describe some of the mechanisms of treatment resistance to androgen deprivation therapy, particularly those related to lineage plasticity and the emergence of neuroendocrine transformation. This is something that we've been deeply involved in over the last 5 to 10 years. And then describing some of the new therapeutic advances for the treatment of advanced prostate cancer. This is an area that's undergoing rapid flux, and excited to share some of the advances here today. I always like to start with a case. This is actually a patient of mine that presented a couple of years ago with de novo metastatic disease to the bone and lymph node, had Gleason 4+4, so high-grade prostate cancer, adenocarcinoma, on his initial prostate biopsy. And as we routinely do now, had next generation sequencing showing a typical TMPRSS fusion. And we see that in about 50 to 60% of patients. PTEN deletion, he was microsatellite stable. We'll come back to this in terms of the genomics. As we now do, we do intensified hormone therapy where we not just give Lupron to lower testosterone levels, but we also give additional androgen receptor blockers. So he was started on abiraterone prednisone, had a really great biochemical response. So PSA from 40 at diagnosis down to 0.6. But as we increasingly recognize, as we potently inhibit the androgen receptor, we sometimes see the emergence of disease that doesn't really depend on the androgen receptor. It doesn't make a lot of PSA. And so increasingly we're doing imaging to really guide the surveillance of those patients. And lo and behold, he had a CT scan about 6 months after starting therapy that showed these new hypodense lesions in the liver, concerning for new liver metastases. We, of course, biopsied one of these lesions and sure enough, showed high-grade carcinoma with neuroendocrine transformation, a high proliferation score with a Ki-67 of 70%. This did not show any of the canonical prostate cancer markers that we see, including NKX3, which is sort of our lineage-specific marker. He had sort of the classic genomic features of neuroendocrine transformation with RB1 loss, P53 mutation, was microsatellite stable. As we typically do, we extrapolate from our thoracic oncology colleagues and treat these patients with a platinum-based regimen. He had a good response, but as we often see, this is relatively short-lived and had subsequent progression. We'll cycle back to his case as we think about some of the new and emerging therapies in this important subset of prostate cancer. So I just want to kind of highlight what's the outline for our talk today. We'll have a couple of slides just setting the stage for prostate cancer, probably a review for the most of you, and then really talk about some of the cutting edge things that have really developed in prostate cancer over the last few years. PSMA PET and metabolic imaging has really transformed the way that we manage patients with prostate cancer. Using more intensive androgen receptor blockade upfront has really become the standard of care, and we'll highlight that. And then we'll look at some of the genomic features that we look at to really guide treatment decision-making in prostate cancer. We'll come back to the lineage plasticity, a big problem that we see in prostate cancer and neuroendocrine transformation, and some of the new kind of technologies that are out there with therapeutic approaches in advanced disease. So just to set the stage, prostate cancer is a global health problem. And as life expectancy improves in many parts of the world, we expect this burden of disease to actually increase, not decrease in the years ahead. Already, this is the fourth most common cancer diagnosis globally, and the eighth most common cause of cancer death, men and women, even though this is a male-only cancer across the world. And if you look at the distribution of mortality in the map on the right, you can see where it's distributed. We expect this burden to actually increase, not decrease, as patients and people in this part of the world live longer, especially given some of the modifiable environmental factors such as diet, obesity, et cetera, that contribute to prostate cancer risk. So this is a big problem. Access to treatment, developing new therapies for advanced disease really means at the forefront of what I work on. I think it's important just to set the stage and really talk about the clinical disease states. Rather than thinking about prostate cancer as stage 1, 2, 3, and 4, the way we think about other cancers, we really think about it as a clinical disease states. Are you castration resistant or sensitive? Meaning, if we lower your testosterone, which is the fuel for prostate cancer, the central driver, are you still responsive to that therapy? And are you metastatic or not? That kind of 2x2 gestalt allows us to place patients in categories that guide treatment decision-making. It's important to realize that even in the advanced setting, even in patients with metastatic prostate cancer, death from other causes, particularly cardiovascular disease, remains a major problem. And even in the metastatic setting, over 20% of our patients die from causes other than prostate cancer. So along the way, managing the cardiovascular morbidity of our patients, given the age, managing their lipids, reducing those risk factors as best we can, and always thinking about the risk benefit and what's the expected life expectancy of our patients is super important. This is sort of the classic androgen signaling axis that we see in prostate cancer. For over 70 years, blocking testosterone and reducing testosterone levels has been the standard of care in prostate cancer, and that hasn't changed. The way we do it has changed. We used to use estrogens, we used to use surgical bilateral orchiectomy, and now we have better agents that are better able to temporarily reduce testosterone, but allow recovery. And we use intermittent hormone therapy increasingly for our patients. And so the agents you can see listed in red, we have first generation compounds, including those like Lupron and Zoladex. We have some newer agents such as relugolix that more rapidly block testosterone, but they all work about the same. And the goal is really lowering testosterone production. It's important to recognize testosterone is not only produced from the hypothalamus pituitary gonadal axis, but also from other sources in the body, especially the adrenal gland. And that's actually an important source of androgens that fuel prostate cancer growth. Long time ago, we used to use ketoconazole to block that production. Increasingly, we use more selective inhibitors such as abiraterone, which has been in use now for over a decade, and even some newer agents that are coming into clinical trial testing. Downstream, we can block the testosterone receptor. First generation compounds that do this are things like bicalutamide, flutamide, dilutamide. Increasingly, we use more potent blockers of the androgen receptor. So enzalutamide, apalutamide, darolutamide, those are all FDA-approved agents that we use in this setting. So that sets the stage. Let's talk about some of the recent advances in prostate cancer, because I think there's been a lot. And I'll start with next generation imaging. And this really refers to metabolic imaging, PET imaging, that really has transformed the way that we think about and manage patients with prostate cancer. And foremost among this is PSMA PET. I'm sure many of you have taken care of patients that have had PSMA PET imaging. It's really hard to underestimate, especially in the localized and recurrent setting, how much this has really transformed the way that we manage patients. A schematic of how we think about the PSMA protein. This is a transmembrane protein. Back in the old days, we used to have agents that targeted the intracellular domain of this protein, and they just weren't very good as diagnostic or therapeutic agents. Now we have many, many different ways to target the extracellular domain, especially the small molecule inhibitors of the enzymatic domain on the extracellular space. And that's really what's enabled us to transform the diagnostic accuracy of detecting prostate cancer. In the advanced setting, about 80 to 85% of prostate cancers are highly PSMA avid. There are a subset that are PSMA negative, as we'll talk about, but this is a very accurate imaging tool. And on the right are images from a PET scan that I did of a patient of mine with a rising PSA after surgery. Using conventional imaging, such as a CT scan, we never would have detected where this patient's cancer was, what was producing the PSA. Lo and behold, this patient has mediastinal nodes that show pretty bright uptake on PET scan. That's really guided our management. UCSF and UCLA were the first sites in the country actually to gain FDA approval for use of PSMA PET imaging in the recurrent setting. And this was a study that really led to the FDA approval. This was a trial of PSMA PET imaging after biochemical recurrence. So PSA that rises after surgery or radiation, and really looking at positive predictive value as well as sensitivity as endpoints in the study. You can see that this clearly performed quite well. The positive predictive value was over 90%. You detect extrapelvic distant metastases at a much higher rate than you would with conventional imaging. And it's important to realize that you can detect disease even at very low PSA levels. So far below what we would expect to detect metastases using conventional CT scans, bone scans, we can detect disease at a much lower level. So even when the PSA is less than 0.5, so very low level, in patients that have had prior treatment for their prostate cancer, about 40% of the time we detect at least one site of disease. You can see the breakdown of the sites of detection. So this study led to initial FDA approval. Subsequently, there was a study even for initial staging. So for newly diagnosed patients that fall in the high-risk category based on their Gleason score, their tumor stage, we now use PSMA PET imaging because it's just more accurate, particularly when it comes to sensitivity. You detect extrapelvic disease and distant metastases at much higher rates than you would with a CT scan and bone scan. And this has really transformed our impact in terms of management. We now use a lot more multimodal therapy, including hormone therapy, radiation, whereas before, these patients might have gone for surgery when that may not have benefited them if they had a significant amount of extrapelvic disease. Another use of PSMA PET imaging is in the metastatic setting, and this whole new category of what we call oligometastatic disease. So if you have just a couple of spots on your PET scan, less than 3, less than 5, the cutoffs have varied from study to study. Does that improve outcomes if we target those lesions with metastasis-directed, particularly stereotactic radiation treatment? We don't know yet whether this impacts long-term survival, but we do have phase 2 studies suggest that it might. On the top is what's called a STOMP study. This was really the first one to show a proof of concept. So these were patients with a rising PSA after prior local therapy who underwent a different type of metabolic imaging. This, in this case, was with choline PET scans. But the principle is the same. Can you target these lesions, or you just observe patients till they develop more symptomatic or progressive disease? The primary endpoint of this study was really the time to initiation of systemic therapy with hormone therapy. As you might expect, about 70–80% of patients had a PSA drop when you target their metastases with radiation. That translates into a delay in the time to use of systemic therapy. There's another trial called SABR-COMET. This was actually a trial across cancer types, so not just prostate, but lung and other cancers, looking at targeted radiation based on the use of metabolic imaging with continuation of whatever is considered the standard of care with a systemic therapy. This trial actually showed an improvement in overall survival, albeit underpowered and not the primary endpoint. And so it's really intriguing to think that we can use metabolic imaging to really guide radiation when appropriate. And that's important because the patient selection piece is super important. We're getting imaging at one point in time. Does this really make sense to target metastases with radiation for our patients? But it's become a huge question in our field as to who's the right patient for that type of multimodal approach. So this is really our current state. We know that PSMA PET and metabolic imaging has significantly improved the accuracy of newly diagnosed and biochemically recurrent patients, patients who have a rising PSA after surgery or radiation, as well as many studies have shown that this impacts the management. So if you ask clinicians, what would you do before and then after the PET scan, for sure there's a change in management in 30 to 40% of patients, including the use of metastasis-directed radiation. It's also enabled us, as I'll talk about in a later portion of the talk, with our radioligand therapy, things like lutetium PSMA, to select the right patients for treatment. But we don't know yet, does this exciting technology actually improve survival outcomes? We don't know, and we may never know. There's just not been randomized trials looking at the use of this type of imaging versus not. Does this translate into improved outcomes for our patients? Unfortunately, the technology has really outpaced our ability to design these trials, and it may be too late to really answer that question because it's come such a standard of care in this setting. Furthermore, in the advanced setting, in the castration-resistant metastatic setting, where I see most of my patients, we see a lot of use of PSMA PET, but we don't really know how to use it. We don't have standard criteria to define progression, to define response. Is this a surrogate endpoint for overall survival in the setting of a clinical trial? We don't know. There are trials underway to really answer that question. But again, even in the advanced setting, this is where the technology has really outpaced our ability to know what to do with the information. And there is a risk of using this really sensitive imaging tools to lead to a premature switch in therapy when patients still clinically benefiting. And we see that in patients that are referred to us. So I'll next talk a little bit about what we call intensification of hormonal therapy. And on the top, you really see kind of the landscape as it looked probably 6-7 years ago. It was really just a blank slate. Someone presents with more advanced prostate cancer. They haven't yet had hormone therapy. Let's put them on Lupron and ADT backbone and see how well they do. And now we know that that's just not sufficient. Now that we have more potent blockers of the androgen receptor, intensification of hormone therapy has become the standard of care for all patients with metastatic prostate cancer. And increasingly, we're trying to refine our techniques, really define based on the volume of disease. So are you low volume versus high volume metastatic disease based upon the amount or number of metastases and location? High volume defined based on the presence of visceral metastases and a large number of bone metastases. In those patients, we know that intensification of therapy is important. Increasingly, genomic biomarkers are becoming important. There are certain ones that are for sure high-risk features, PTEN loss, RB1 loss, some of the classic tumor suppressor genes. When those are lost, we know patients have a shorter time to resistance. Should that change management? We don't really know, but those are some of the active questions that are being asked. So for all patients, we combine androgen deprivation therapy with a second-generation hormonal blocker. One of the open questions in the field is triplet therapy. This refers to patients newly diagnosed with metastatic prostate cancer, where we give not just the hormonal therapy backbone with the doublet, but add on top docetaxel chemotherapy. And this is an open question, but one where for patients with high volume de novo metastatic disease, increasingly this is part of our practice patterns. This just shows you the highlight of kind of all the phase 3 trials that have been done in this space. A lot of it is sort of me too trials of one androgen receptor blocker followed by the other. But I think one of the striking things, despite the fact that we shouldn't compare across trials, we do see pretty similar hazard ratios for overall survival that pretty much uniformly tell us that, yeah, Lupron alone or androgen deprivation therapy alone is really not the standard of care. And we need to be intensifying our hormonal blockade for patients with metastatic prostate cancer. How good are we at really seeing whether this is uptake in the community? And these are real world data taken from the CancerLinQ database run through ASCO. And somewhat discouragingly, we kind of plateaued around 65% of patients are getting intensified hormone therapy in the metastatic setting, despite probably now 6-7 years worth of clinical trials showing us that this benefits patients with respect to long-term survival. Of course, there are multiple barriers to this. It's not just lack of awareness of the clinical trial results, but financial toxicity of these oral agents. There's certainly comorbidities and cardiovascular and neurotoxicities of our therapy, patient comorbidities, as well as just, patients like the fact that when you're on ADT, you just get an injection every 3 months. You don't have to worry about taking a pill every day. And that certainly influences sort of practice patterns as well. So I'll next talk about some of the genomic features that we use to really guide management for our patients. And this is really where I'd like to see the field move more. We have kind of always in front of us is breast cancer management, where we have very strictly defined molecular categories and defines how we treat patients. In prostate cancer, I think we're moving in that direction, but still a lot more ways to go. And in particular, it's the DNA repair pathway that we think is super important. So this is actually a seminal paper that was published now a number of years ago in New England Journal, looking at germline mutations in metastatic patients in predominantly Caucasian patient population. But you can see that probably in total, about 10% of patients with metastatic prostate cancer have a pathogenic germline mutation. So this screening for hereditary mutations has now become standard of care for all patients, regardless of family history. And this is really something that still the uptake is not as good as we'd like to see, but hopefully improving. Amongst those patients with germline mutations, BRCA2 alterations really predominate. This is about 45 to 50% of all alterations. But it's important that patients get tested for some of the other genes in this pathway, as well as some of the other risk factors, including the Lynch syndrome, so the microsatellite genes, you can see in a small percentage there as well. It's important not to discount the importance of somatic profiling. So I always tell patients there's two components to genetic testing. We have to do hereditary testing, but we also have to test your tumor. And luckily, most of the drivable, targetable mutations that we see in prostate cancer are present in the primary tumor. So if you take BRCA2, about half are hereditary, but half are tumor only. So if you have a patient that only gets hereditary testing, you're missing half of the picture. And that's important because our PARP inhibitors, like we use in breast and ovarian cancer, are also FDA approved to use in prostate cancer with BRCA alterations. If you look at all the DNA repair pathway alterations, it's about 20 to 25% of patients. That's a pretty large number of patients if you think about the incidence of prostate cancer. So we're missing a lot when we don't do this, both components of genomic testing, germline and somatic. Microsatellite high tumors, so tumors that have a really high mutational burden with a lot of mutations that respond well to immunotherapy, are a small percentage, but important not to miss. This is about 2 to 3% of prostate cancer, lower than what we see in colorectal and endometrial cancer, et cetera, but still important to detect. And just looking at some of the data for the PARP inhibitors, we know that these agents don't work as well across the board in terms of the DNA repair mutation family. So what I tell patients is, like, if you have a BRCA mutation, at some point in your treatment course, we should give a PARP inhibitor. For the other genes in this family, it's less clear. So in particular, ATM, PALB2, CDK12, these are all lumped together. And the FDA approval for PARP inhibitors really encompasses all these genes. But we know that those PARP inhibitors don't work as well in these genomic subsets. And there's a lot of work, a lot of clinical trials ongoing. How can we better target some of the other genes in this pathway? And this is depicted on the right with a waterfall plot. You look at the patients who respond, so PSA or tumor shrinkage. You can see the blue bars are really those patients that have a BRCA alteration. Those are the patients that really respond. PALB2 probably falls in that category. But some of the other genes, not a lot of activity. We need to find other better ways to target these patients. And it's a sizable chunk of patients that we see in the clinic. Microsatellite instability, as I said, 2 to 3% of prostate cancer, but important not to miss it because these patients can have a significant response to immune checkpoint inhibitors such as pembrolizumab. These are data coming out of MSKCC, just showing you that you can see durable responses in the majority of patients with microsatellite high tumors. So I want to talk a little bit about lineage plasticity, and I'll circle back to the case that we presented at the beginning. This is a slide I put together a few years ago that really just highlights the fact, and that one of the challenges we have in prostate cancer is under intense hormone therapy where we're blocking the androgen receptor, you do see this lineage plasticity, this transformation from an adenocarcinoma to more of a neuroendocrine phenotype. And unfortunately, it's not as clean as just putting patients in different buckets. There's a lot of heterogeneity, both within a tumor, across tumors, across patients in terms of this kind of transformation. But in general, you see this decreasing dependence on the androgen receptor to drive tumor growth. This is coupled with pathologic features that change, and we start to see actual frank small cell neuroendocrine prostate cancer when we biopsy patients with neuroendocrine or with metastatic castration-resistant disease. There is this phenomenon of what's called double negative prostate cancer. These are tumors that have lost androgen receptor expression, but don't yet or will not develop neuroendocrine markers. And this whole category of double negatives is a big focus to really see, is this a distinct subset? Or is this just really a transitional state on the way towards neuroendocrine differentiation? But in advanced prostate cancer, this is where we really struggle, is how to treat these cancers. Transcriptionally, they flip from being more of a luminal to a basal. So this kind of copies some of the nomenclature from the breast cancer world. And increasingly, we're using metabolic imaging because we can't biopsy every site in a patient. We use PSMA PET as a fairly lineage-specific marker of adenocarcinoma. And we certainly see loss of PSMA expression and uptake in some of these tumors. So this has really been the major focus of us at UCSF. And for a long time, we've undertaken metastatic biopsies in the castration-resistant setting. We did this study a number of years ago with now over 300-400 patients that have undergone biopsies. And one of the striking findings was just how common small cell neuroendocrine prostate cancer was. We used to think of this entity as quite uncommon, and now we know it's actually pretty common. We found it in about 15% of all biopsies that we undertook, regardless of our clinical suspicion for neuroendocrine cancer. So this is pretty striking, and it's really led to a lot of focus in this area. How can we treat these patients with advanced disease? Clearly, the morphology changes. You can see the adenocarcinoma type of features on the right, on the top right. These are classic sort of features that we see under the microscope. And some of the features with small cell, much more crowded nuclei, a lot of molding, a lot of darker cells there that you can see. And this really has led to us to try to understand what are the genomic and transcriptional regulators of this process. The transformation towards neuroendocrine differentiation is really an epigenetic phenomenon. We don't see a lot that happens at the DNA level, but we see a whole lot that happens at the RNA level. And there are certain switches that happen at the transcriptional master regulator level that really drive the transformation towards neuroendocrine prostate cancer. This was an analysis we did based on the RNA sequencing that we did from these metastatic biopsies. You can derive what are the transcriptional factors that are most active in this transformation. There's still a lot to learn. You know, is there a temporal sequence to this process? Which ones are essential? Which ones contribute but are not essential? And then what I care about the most are these druggable? You know, we don't really have great ways of targeting transcription factors for prostate cancer or other cancer treatment. That may be changing with some of the degrader, protein degrader, and other techniques that we now have in the clinic. And there are clinical trials underway to really target some of these transcriptional factors as shown in the arrows there. Certainly the detection of small cell NEPC, no question about it, is prognostically important. So when we find it, it is important. We look by histology, by gene expression, or when you combine the two, no doubt this is associated with shorter survival, and it's really, really high unmet need for our patients. The way we treat these patients, no surprise, we use a lot of platinum-based chemotherapy. Just like in small cell lung cancer, you see responses, but they generally are short-lived. And we're really searching for options beyond platinum-based chemotherapy. I always prefer a clinical trial for our patients. There are agents that we borrow from the small cell lung cancer literature, including lurbinectedin, the topotecan, taxanes, et cetera. Generally pretty limited activity with those agents. There's only been one clinical trial, a randomized trial of platinum-based chemotherapy as shown on the right. This actually did show a survival benefit. And so we do use platinum taxane chemotherapy fairly commonly for these patients. I'm not going to go through this in detail, but just to say that since we put out our findings a few years ago of just how common this was, it's really led to an explosion in the number of trials and treatment options specifically for neuroendocrine prostate cancer. It used to be that we thought, oh, this is rare, less than 1% of the time do we see this. Now we know it's common, and it's gratifying to see that there are multiple different treatments being evaluated, running the gamut from immunotherapies to different antibody drug conjugates to different small molecule inhibitors, and we'll come back to some of that later on. So I want to spend the last part of the talk just talking about, you know, some of the new technologies in prostate cancer, and I'd say that where we are right now is a little bit, you know, to simplify it, is really just looking at what are the surface antigens that are most commonly expressed in the different subtypes of prostate cancer, and how can we best target those? What are the payloads that really matter the most? And where we've landed are three really big categories in the way of antibody drug conjugates, bispecific T-cell engagers, and then radioligand therapy. So I'll go through examples of each. It's a very, very active area in terms of drug development, and certainly can't cover everything in this talk, but just to say that it's a really, really exciting time, and we're seeing some really promising early phase clinical trial results. So starting with the antibody drug conjugates, I've been fortunate to work on a project that's actually homegrown science. So this target was actually discovered here at UCSF. This was discovered through an unbiased library screen of prostate cancer tissues. And there was a specific epitope of CD46, which normally we think of as a negative regulator of the complement cascade. But it turns out there's an epitope that turns out to be quite tumor specific. And you can see the expression array on the left. This has a high therapeutic index. It's mostly expressed within the prostate with limited expression in other tissues. And you can see some of the examples of the expression patterns on the right. So already this jumps out as, yeah, this might be a promising target. When you look at clinically available public databases of prostate cancer tissues in patients, you can see there's a significant enrichment for genomic amplification as shown on the left, as well as positive expression of this epitope, not just in adenocarcinoma, but also in small cell neuroendocrine prostate cancer, which we just talked about. So as compared to PSMA, we think CD46 might be a somewhat lineage independent marker. So could we identify targets that are present despite the transformation that happens in a subset of patients? This just shows some additional data comparing the RNA-seq and the transcriptional levels of CD46 as compared to PSMA, which is our gold standard in clinic right now. And you can see that on the left, there's actually less variability in expression, a tighter range in terms of CD46 that on average is higher than what we see with PSMA. And in those neuroendocrine prostate cancers that have really transformed and undergone that lineage plasticity, you see retained CD46 expression as compared to PSMA, where as expected, you see loss or decrease in expression during that transformation. So this has really led to a lot of excitement around the target. We translated those initial laboratory findings actually into a clinical trial with an antibody drug conjugate. This is an antibody that binds to CD46 with a linker that's taken up into the cell, cleaved via cathepsin-mediated process. And then the payload is MMAE, which is a microtubule targeting agent. There's a lot of work ongoing to really optimize these antibody drug conjugates, but this gives you a general schematic of how we think about these ADCs, which not just in prostate, but in other cancers have really transformed the way that we take care of our patients. We led a phase 1 trial here at UCSF and a number of sites that just completed, showing some encouraging preliminary efficacy, and now have an ongoing or just about to start registrational phase 2/3 trial with this ADC to really understand its impact in advanced prostate cancer. A lot of work ongoing to optimize these ADCs. Can you use smaller molecules? So one of the challenges with an antibody is it stays in circulation for a long time. And even if you have a really good linker technology, the payload tends to fall off. So for the MMAE type compounds, that leads to a lot of neuropathy and side effects related to that. Can you maximize bystander effect? So once the payload kills the cancer cell, can it spread to an adjacent cancer cell and kill that cell? That's important because we know that whatever your target you're selecting, there's going to be heterogeneity. Some cancer cells are going to express at higher levels than others. The bystander effect is important. And that's been an important part of the engineering of how we think about the ADCs. A lot of work being done with the linker design. Can we make it as stable as possible in circulation, yet cleavable in the tumor microenvironment? Anti-drug antibodies, which eliminate the clearance of the ADC, have been a big problem. I think some of the newer generation compounds have really been able to solve that issue. We're increasingly seeing bispecifics or trispecifics, not just targeting one, but several different tumor antigens to improve that tumor specificity, knowing that any individual target is not perfect. And then payload delivery, there's a lot happening beyond just MMAE. The topoisomerase inhibitors, I'd say, have really become at the forefront in terms of oncology therapy. This is best evidenced by Enhertu. This is a new ADC that's approved now for HER2 positive cancers, regardless of origin, not just breast, but across solid tumor oncology. That's really been at the mainstay, but there are even payloads beyond that looking at targeting the DNA and achieving that kind of DNA damage that may lead to cancer cell death. I'll next talk about the bispecific T-cell engagers. I forgot to mention earlier the diagram on the right. These are some of the targets that are currently in clinical trial evaluation in prostate cancer. It's not all encompassing, and it really runs the gamut from both adenocarcinoma to neuroendocrine cancers. What bispecific T-cell engagers do is, we know in prostate cancer, this is a very immunologically cold microenvironment. We don't see the kind of infiltrating T cells the way you do in melanoma and lung cancer, bladder cancer. Those are the cancer types that really respond quite well to checkpoint inhibitors like pembrolizumab, nivolumab, et cetera. We need to do something different in prostate cancer. We have to do something more proactive to activate the immune system to attack the cancer. The bispecifics really bind to the T cells and bind to the tumor directly, really try to bring the two in close proximity to really engage in that T cell mediated cytolysis of the cancer cells. These agents are active, but have a lot of side effects. And in particular, cytokine release syndrome, which some of you may have seen these patients in the hospital, fevers, hypotension, edema, and then neurologic toxicity, ICANS, confusion, somnolence, et cetera, can be serious, serious issues for our patients. It's the reason why we need to admit these patients to the hospital for the first couple of doses, because the risk is so high, we have to be able to intervene. There's a lot being done to try to mitigate that risk. We uniformly now use step dosing, where we'll start with those low dose, work to an intermediate dose, and then eventually work up to a target dose, and that does help mitigate the risk. There's newer bispecifics that more preferentially bind to the tumor antigen rather than the T cells, and that also seems to mitigate risk. And then some new techniques really using masked epitope antibody binding that really, if your antibody only binds in the microenvironment, might that help lessen some of the toxicity as well. One of the targets that we've been interested in when it comes to bispecifics is DLL3 in neuroendocrine prostate cancer, as well as in small cell lung and other neuroendocrine phenotypes. So we're always searching for targets, especially in neuroendocrine prostate cancer. This is a pretty good target. This DLL3 is part of the developmental pathway. It's an atypical Notch ligand. So in development, embryogenesis, it's expressed. It's silent in normal adult tissues, but then aberrantly overexpressed in neuroendocrine cancers. About 80% of our neuroendocrine prostate cancers express this target. It does have some off-tumor expression in CNS tissues, but generally pretty clean in terms of target expression. John Chow here at UCSF led a lot of our experiments with a bispecific T-cell engager targeting DLL3, tarlatamab, in PDX models that are bona fide neuroendocrine prostate cancer models. So this is the LTL-545 model. You can see significant tumor regression that's sustained with the use of the bispecific tarlatamab antibody as compared to control. And it appears to be expression dependent. So when you look at different models that have different ranges of DLL3 expression, you see different ranges of depth of suppression of tumor growth. And this is really translated in the clinic. We see this where patients with different levels of DLL3 expression do have a differential range of response to therapy. So we actually led a phase 2 trial of tarlatamab in patients with neuroendocrine prostate cancer and took a pragmatic definition of how do we identify these patients if we can't get a biopsy in every single patient, and looking at a composite definition of whether you had small cell histology, whether your genomic showed P53, RB1, or immunohistochemical features of neuroendocrine differentiation. And so circling back to our case that I mentioned at the beginning, this patient was actually right time, right place. We're able to enroll on the study, had DLL3 testing that showed a pretty high level of expression, enrolled on the study. This was a step dosing, so patients have to be admitted for sometimes 2 to 3 weeks in a row. They go home, they come back, but we have to manage the cytokine release syndrome. This patient did pretty well and had gratifyingly a very good and sustained response. These numbers of having a sustained response for over a year is quite good. This is a very aggressive tumor type, but really gratifying to see the kind of response and with his liver metastases that we saw. Subsequently did have progression. We're trying to learn what are the mechanisms of resistance there, but really a nice response to this bispecific. One of the other exciting bispecifics that has really come at the forefront in prostate cancer is xaluritamig or AMG 509. This is targeting STEAP1. STEAP1 is expressed predominantly in adenocarcinomas, less so in neuroendocrine, but really been quite exciting. They released data last year and just updated at our European Oncology meeting a couple of weeks ago. The top left shows you the waterfall plot, the PSA responses that we're seeing. Definitely don't know if this translates to long-term survival benefit. So these are intermediate endpoints, but this is pretty impressive for a pretty advanced patient population that has had hormonal therapy, chemotherapy. You can see PSA 50 declines in the majority of patients. There's a trade-off though. This agent has a fair amount of cytokine release, as shown in the top right. Most of the time, this is grade 1. Grade 1 means you have fevers, you might have transient hypotension requiring some fluids. Grade 2 means you have more persistent hypotension or hypoxemia. And grade 3 is really like pressor support. So you can see the kind of breakdown in terms of the severity we're seeing despite the use of step dosing and as well as anti-IL-6 agents like tocilizumab to manage this. Gets better. So I always tell patients it's getting through that hump of the first cycle. By the time you get to cycle 2 and beyond, the CRS risk is much lower. This particular bispecific has a unique side effect of a lot of musculoskeletal side effects. So joint pain, muscle aches, that can be quite bothersome for our patients. On the right, bottom right, this is a patient that actually enrolled on the trial here at UCSF. Just persistent muscle aches, proximal muscle predominant, ultimately had a deltoid muscle biopsy. There's not a dense inflammatory infiltrate, but you see this upregulation of MHC1 that really indicates that inflammatory type of myopathy. And this patient's required to be on steroids ongoing. It's a trade-off. This patient has an ongoing response for over a year, but this is part of balancing the toxicities of this therapy. Definitely, these are select group of patients that are fit and eligible to receive this type of agent, but I think this agent's likely to transform care. This particular drug is going to be in multiple phase 3 trials, and I think chances pretty good we'll get FDA approval just based on the activity that we've seen. Finally, I just want to talk about the radioligand therapy. Some of you may have seen these patients, that get treated. Radiation, prostate cancer, we've long thought of as a very radiation-sensitive cancer, but now we have ways of systemically delivering radiation in a targeted fashion using theranostics. So starting with PSMA, can you have a compound that binds to PSMA and delivers therapeutic doses of radiation? The lead compound is lutetium-177, that's the isotope. It delivers beta particle radiation that really damages the DNA and kills the cancer cells in that way. It's always coupled with a diagnostic. In this case, PSMA PET uses the same small molecule backbone. And so we can really precisely now select patients. And because lutetium is visible using a SPECT CT scan, we give the dose. The next day we can image patients. You can actually see where is the drug going, which sounds basic, but for the vast majority of oncologic drugs, we don't know once we give it. Where is it? Is it getting into the tumor? We don't know. Now we can actually measure that with the use of imaging and these theranostic agents. This was the first phase 3 study that was done with lutetium called the VISION trial. A lot of flaws in this study. The comparator of standard of care probably wasn't sufficient, but it was a pretty heavily pretreated patient population that had received chemotherapy, hormonal therapy, didn't have a lot of treatment options available. Pretty liberal definition of what it took to be PSMA PET positive. So you had to have a PET scan, you had to have one or more lesions that was positive, and no frankly negative lesions. Treated with up to 6 cycles, standard fixed dose, 7.4 gigabecquerels every 6 weeks for up to 6 doses, with overall survival as the primary endpoint. No question was a positive study. The hazard ratio was 0.62, demonstrating improved survival. This has now become the standard of care. So in the post-chemotherapy, post-hormonal setting, we're using lutetium PSMA 617. We have a pretty high treatment volume here at UCSF. There are subsequent trials that have, as you might expect, can we use this earlier in the treatment course, so before chemotherapy, or maybe even in the hormone-sensitive setting, patients that are just starting hormone therapy, and there are phase 3 trials underway. There's a lot we're still learning about what's the right patient for radioligand therapy. No surprise, the higher the amount of uptake on your baseline PSMA PET, the more likely you are to respond. So can we use more stringent definitions to really predict those patients that are going to do best, especially if we move the agents earlier? These drugs all have toxicity. It's a radiation. There is chance of long-term hematologic, and as we're learning, renal side effects from some of these PSMA-targeted radioligands. Can we give different isotopes? Actinium-225 delivers alpha rather than beta particle. These are heavier particles, kill more cancer cells per particle, don't travel as far. So theoretically, less hematologic side effect risk, but perhaps some higher risk of off-tumor, on-target effects. So PSMA is expressed in the salivary glands and other glands in the body. So it's a trade-off, and we don't really know. There are a lot of trials underway with actinium and isotopes to follow, lead-212, copper-67, and others. It's required all of us to kind of brush up on our physics, but really, you know, it's an interesting blend between medical oncology and nuclear medicine radiology now, and we're kind of finding that multidisciplinary management of our patients is really beneficial to sort of think about options. Adaptive dosing is important. There's patients that have just so much uptake on their baseline PSMA PET. It's almost like a sink. We call it a tumor sink. You're giving the dose, it's a fixed dose, but you're probably not treating all the tumor because there's just so much PSMA expression. So can you use more of adaptive dosing, giving higher doses to those patients with more uptake? Conversely, those patients that have relatively little uptake, and it goes away after a couple cycles of lutetium PSMA. Do you really need to give all 6 cycles at a fixed dose? We're increasingly pausing, spacing out the dosing, trying to mitigate that bone marrow toxicity risk, and there are prospective trials underway. And then combinations. This is a DNA damaging agent. Can you combine it with an immune checkpoint inhibitor? Can you combine it with a PARP inhibitor? AR pathway inhibitors may upregulate PSMA expression, at least in the short term. So could you use that as like a prime to then dose with lutetium? These are all active questions. This is just one example of a study we published last year looking at just a single dose of lutetium, almost like an immune prime, followed by a checkpoint inhibitor, pembrolizumab. Pembrolizumab by itself doesn't work great in metastatic castration-resistant prostate cancer, but we saw some pretty encouraging activity in this single-arm study, and responders seem to have better generation of immune response compared to non-responders. So this is something that we're sort of actively looking at these different combinations. So this is my final slide, just a take-home points. Next generation imaging, it's transformed the way we manage patients with prostate cancer. We don't know how to use it in advanced disease other than to select patients for lutetium PSMA treatment, but more is coming in this regard. Every patient with metastatic prostate cancer should get combination hormone therapy unless there's a very good reason for them not to. So a patient on Lupron alone, that's not sufficient. We should get genomic testing, both somatic and germline, for all our patients, because that impacts management. PARP inhibitors are approved to use, but there's still a lot to learn. And it's really the BRCA mutated patients that respond best. We worry a lot about lineage plasticity. We have to be vigilant for it. We have to biopsy for it. Increasingly, imaging is going to play an important role in identifying it. And then I've talked about some of the cell surface antigen targeting techniques, the ADCs, the bispecifics, the radioligands. A lot happening in this space, and certainly more to come. So I just want to thank everyone at UCSF, mentors and collaborators along the way. I've been here since internship 15 plus years ago, and certainly had a bunch of wonderful mentors along the way. And yeah, just thank you for your attention.
Fabulous, thank you. Let me start with one or two. Strikes me that the complexity of what you just presented is awesome compared to the way we used to think about managing this disease. And the prostate was one of those diseases that general oncologists took care of in the community. While staying this side of sort of diplomacy, is the complexity now such that you need to see a prostate specialist to manage the disease effectively?
Yeah, it's a great question. You know, obviously I'm biased. I'd say yes to that question. I think that not only community medical oncologists, but actually a lot of urologists manage patients with advanced prostate cancer. And, you know, I think there are advantages to that in these large practices, efficiency of care delivery. But when you start talking about castration-resistant disease, given all the options that are available, plus the toxicities of therapy, you know, things like radioligand therapy can lead to renal TMA and long-term nephrotoxicity, for example. So we need to have that kind of specialized expertise to manage these patients.
Yes, one more. The neuroendocrine transformation Is that a natural history of the disease, or is that under the pressure of the therapy that happens?
It's a great question. We think it's under the pressure of the therapy that happens with androgen deprivation therapy. If you're blocking your testosterone for that many number of years, with or without these more potent agents, it's a resistance escape mechanism that the cancer is going to learn how to define, grow despite a blocked androgen receptor.
Got it. Open it up and say who you are.
Hey, Earl, great talk. I'm Sam. I'm an oncologist here. The same patient. It's been really interesting to watch the definition of metastatic, which is local activation, PSMA PET. And I'm just curious, I thought I saw you mention that sometimes you might think about starting systemic therapy, other times there might be like a radiation approach for metastatic disease. You also said it's kind of here in today's world. So I was just curious if you can say a little more about that.
Yeah.
If there is like a radiation-only approach to some cases of metastatic disease, is that ever curative intent, or is it really considered systemic once there's even any small evidence of metastatic?
It's a great question. It's sort of the wild, wild west. You refer a patient over to radiation oncology, they're going to radiate what they see. So you have to be pretty selective about it. I always counsel patients that we don't think of it as curative. If you have the mental framework of you're going to give intermittent hormone therapy, sometime you're on systemic therapy, sometimes you're off. If the radiation is viewed as a way to potentially drive down the disease, delay the time to need to restart hormone therapy, that's the context in which I really think about it. There are outliers that can go 3, 4, 5+ years without PSA recurrence following metastasis-directed therapy, but that's definitely the exception rather than the rule, for sure.
Yeah, question.
About 80 people in the audience watching online. One of them asks if there's a strong family history of prostate cancer. Are there other screening tests besides PSA that you recommend and that are covered by insurance? Are there any genetic tests to predict the risk of prostate cancer?
Yeah, that's a great question. I mean, prostate cancer is a very heritable type of condition. So even if you don't have one of these inherited mutations like in BRCA, if you have a first-degree relative, certainly that increases your risk. And there are changes in the management of screening in terms of age at which to start PSA screening. Fortunately, we haven't found anything that's better than PSA. It's far from a perfect tool, but it's still one of the better tests we have. There are urine-based biomarkers, and increasingly MRI of the prostate is being used in high-risk populations, but still the standard of care would be PSA-based screening.
And I know this is a complete other lecture, but is the routine PSA screening above whatever age, is that now a done deal? Is that an answered question or still controversial?
I think it's still controversial. I mean, one of the things I couldn't cover just in the interest of time was just the increased incidence of metastatic prostate cancer at diagnosis that we've seen since the 2012 recommendations from the Preventive Task Force that sort of recommended against PSA screening. We're still battling that. There's been a for sure uptick in the number of metastatic patients at diagnosis. Generally, what we think is that PSA screening should be done, but then after that, it requires a risk stratified approach. And I would say that MRI and maybe PSMA PET allow us to better select those patients that should go on to a prostate biopsy. If cancer is detected, another risk stratification step. If you have Gleason 3+3, low risk prostate cancer, that's a patient where active surveillance should absolutely be recommended.
So is that also asked and answered that a low risk local prostate cancer can be managed with watchful waiting as opposed to more aggressive treatment?
I think it's generally, given the timeframes and the amount of data we have now with long-term outcomes of these patients, if you have a low risk prostate cancer defined based on the clinical characteristics, coupled with, we increasingly use genomic features. There are different genomic classifiers like Decipher and Oncotype DX. If you're in that low risk category, there's good data that you're safe to watch. It's not watchful waiting so much as active surveillance. You do need the follow-up. You do need the follow-up biopsy. There's about 35% of patients will have an upstaging and upgrading of their cancer over time. Those patients probably need treatment.
And are the markers usually in sync, that the Gleason lines up with the genomics and everything's sort of straightforward, this is low risk, or is there sometimes dissonance where one says one thing and the other says another?
There's definitely dissonance. Gleason score is far from perfect. The interpathology concordance is definitely far from perfect. I think increasingly, not just genomic classifiers, but AI. This is a role for AI, and there already is an AI platform based on the pathology that's part of our NCCN guidelines to really help better risk stratify patients.
Right. You have others? Yeah.
Aggressive anti-androgen therapy associated with muscle weakness and psychological changes. How do you approach that in your patients?
Yeah, it's a big challenge. The question was really about androgen deprivation therapy and some of these combination hormone therapies, how they affect muscle mass and cognitive change, some of these toxicities. That's actually where we spend the bulk of our time with the patients in the hormone sensitive setting. There's no one right answer. For sure, there's been randomized trials of exercise and supervised exercise programs improving fatigue for our patients. The cognitive effects, we always look at whether if they're on combination therapy, not all those agents are created equal. So enzalutamide in particular has a little bit higher risk of cognitive side effects and neurotoxicity. So we might switch from one agent to the other. We might drop the agent and just go with Lupron alone. Or if the patient has a really good response, just stop therapy and give an intermittent, sort of treatment break just based on those types of side effects. So it's an important part of what we're doing when we manage patients.
Things usually improve when you stop.
Things usually improve. It's important to know that testosterone recovery doesn't happen right away. You stop hormone therapy, it takes on average 3 to 4 months. About 10% of patients don't recover their testosterone at all. So there can be a long-term impact of it for sure.
I assume you never give testosterone.
Not as standard of care. We get a lot of patients ask us about it. I will say I have a handful that just have said, you know what, I absolutely want it, and
I feel so bad.
we'll do it. We'll do
We'll
it.
do it.
Yeah.
Sam.
Okay, so another question about treatment. So you mentioned that ADT alone is not usually the appropriate first-line systemic therapy anymore for most people, and then there's multiple options of stuff to add to that. And then I know recently they're kind of still stacking and they're adding ADT plus chemo plus Tabifred. Can you talk a little bit about like older patients?
Yeah.
Other folks where you would do a happy medium?
Yeah.
How you think?
It's a great question. So this so-called doublet versus triplet question, should we add docetaxel on top for a newly diagnosed hormone-sensitive patient with metastatic disease? Say for the vast majority, we're still using doublet. There's no randomized data of plus minus docetaxel, doublet versus triplet. It's one of the big gaps in our field, and I frankly don't think it'll be answered. For a de novo metastatic high volume, per the definition I showed, younger patient who's fit for chemotherapy, I do discuss triplet therapy with the caveats. But I'd say for the majority of patients, especially for the older patients, we're still using the doublet with the hormone therapy alone.
And when you talked about targeted antigen treatment, and I saw a whole bunch of antigens, are you talking about like some biotech companies making this thing that'll target that thing and that A, C, and D? Or is this sort of engineered therapy at some point that we're actually going to brew therapy for a specific patient around a set of targets?
Yeah, it's more shared antigens, I would say. I mean, there certainly are personalized sort of antigens and vaccine type of development. I'd say that space is definitely lagging behind. It's really most bang for your buck. Some of these common shared antigens, the ones I showed, are really across patients, but certainly there's a lot of heterogeneity of target expression for sure.
Great. Any other questions out there? One more. And I ask you in terms of the watchful waiting or the active surveillance, it used to be quoted that like 90% of people who tried it couldn't stick with it. Either they couldn't deal with it psychologically or something pops up. What's the number now? Like of people who start that way, how many stay on that path and maybe stay on that path for the duration?
Yeah, it's age dependent. Obviously depends on your expected life expectancy. But in the patients that, are a little bit on the older side, majority, actually more than 50% would stay on surveillance for their lifespan. And so it's a very important tool. We're lucky at UCSF, our urology group has been sort of a leading proponent of active surveillance. So for us, we have sort of long-term data showing that it's a safe approach. If you're in your 50s and you get diagnosed with prostate cancer, low risk, and you're put on active surveillance, they're probably, more than half would eventually need treatment. But if you can delay that by 5-10 years, you're sparing that amount of time.
Does that influence if you're in your 50s? Are you more likely to say to someone, there's such a high chance that you'll break out of this and you'll need something that those patients you may recommend more active treatment early?
Yeah, I think at the initial time that they're put on surveillance, you'll counsel them that the probability, just by virtue of the life expectancy, that you'll need treatment at some point. But a lot of patients still opt for surveillance up front because it's delaying toxicity from the treatment.
And obviously, if you're thinking this through as the patient, it's not just what are the chances that I will, the active surveillance will show that I need to have something done, but what are the chances that my presentation will be metastatic disease? So what are the chances?
Yeah, very low. So that there's good data that you're not gonna, prostate cancer is not like a high-grade lymphoma. It's very rare that you're gonna, in a window of 6 months, 12 months, gonna miss the chance for cure. So that is now very well established for these low-risk patients.
Great. I think we're at time. Rahul, thank you for your leadership and thank you for a great talk.
Thanks, Bob. Yeah, appreciate it.